It is again my pleasure and to say hello and welcome all of you to the School of Medicine and Dentistry in case this is your first event of the day over here. But I would like to say that I've just had a wonderful day sitting in lots of different programming, lots of different talks, whether it was reunion breakfast or it was the med talks or Dr. Linehan's vision statement. But I'm a little biased. I think we've saved the best for last today because my heart is about medical education. And it is my honor and privilege to invite you here to the George Engel Memorial Lecture. Just by a quick show of hands, how many of you either learned from Dr. Engel or, yes, his influence and connection is strong? Well, it gives me great pleasure to introduce today's presenter, who I think in a couple of years we could say, who of you remember David Lambert and were taught by David Lambert, and it will be another cult following like Dr. Engel. Today's lecture is going to be by Dr. Lambert, talking about a century of excellence in medical education and the journey forward. Dr. Lambert is the Senior Associate Dean for Medical Student Education at the University of Rochester, and in his current role, he oversees the medical education program and has served as our leader, our fearless leader, through 3 cycles of our LCME accreditation visits, all with full accreditation, which if those of you who work in the biz of med education, you know that that's quite a feat. He earned his medical degree from the Dartmouth School of Medicine and completed his internal medicine residency at the New England Deaconess Hospital in Boston. Nationally, Dr. Lambert represents our School of Medicine and Dentistry on several groups within the AAMC, but specifically the Group on Educational Affairs, and has contributed to several national competencies and curriculum developments and standards, including telemedicine or revising the medical student performance evaluations. On a personal note, I interviewed with Dr. Lambert in 2011. Actually, it's probably 2010 I interviewed with him, and I've had the privilege of sitting in the front row watching him do his thing. I've seen him with students, I've seen him with faculty, I've seen him with site visitors, I've seen him with chairs of departments advocating and holding this really high standard for medical education and what it is to train and develop the professional identity of a physician. He is a mentor and a role model, and I can't wait for this talk. You all have made the absolute right decision to be here today to listen to this. So it is my honor and pleasure to welcome Dr. Lambert.
Thank you, Dr. Perry, for that very nice introduction and setting the bar very, very high for me here today. So I just got to find here we go. So yes, I'm going to talk about a century of excellence and the journey forward. Welcome to your Meliora weekend. You know, when I was asked to give this talk, it said it's a 100-year anniversary, and I thought, wow, 100 years is a long time. And then I thought how long I've been here, and I thought, wow, 100 years is pretty quick. So I've been here for about a third of that time. I want to acknowledge the legacy of George Engel, and I'm going to touch upon him briefly during the talk along the way. But I also want to thank people in Minor Library who helped me with this talk in giving me books and references that I could use and photographs as well. And acknowledge that Dr. Mark Taubman has written a book that will be available for people that will cover the last 25 years of the school's history along the way. One disclaimer, everything I say is my own thoughts. They don't represent those of my employer or the university. Don't get too excited. It's not going to be that controversial, believe me. And I have no financial interest in this other than I do enjoy my job, and I hope to keep it by the time we're done today. So what I'm going to do is just give you a quick historical view of the last 100 years of the medical school on the basis of the MD program and highlight some aspects of that have endured in our program today, and touch upon some important points in the future of medical education. So as you know, the medical school arose after Abraham Flexner's report, Medical Education in the US and Canada, that was sponsored by the Carnegie Foundation. And it really pointed out that most medical education institutions at that time were proprietary. And from that, the medical school emerged. And George Whipple was chosen as dean of the medical school because Rush Reese felt that he best embodied a person who could bring the science and art of medicine together as a pathologist. The first medical school class had 2 women and 20 men, And 3 of those did a 1-year fellowship during their time here, actually 1 or 2 years, if you look at each individual along the way. And that's an important point that I'm going to return to a little bit later on as well. It was described as a family-sized school by Dr. Jacob Goldstein, who was a member of the first class of the medical school. So in 1929, 15 of the original students and 3 transferred graduated from the medical school. And of those, 13 of them had published research. The class size has grown from the beginning of 22, and you can see here how it grew. In the 1940s, in response to the war effort, there were changes in the curriculum, but the class size increased. And in around 1960, the class size went up to 70. In the book of the 75th anniversary, Bob Joint wrote that the medical school the federal government was threatening to withhold funds if the school did not increase its enrollment size because there was a need for more physicians. And that what's eventually led to the number of 97 in the 1980s. The first MD PhD students arrived here in 1968 and were funded by NIH for a short term, and then NIH revoked the funding in general for MD PhD students. The circumstances were different from those that we've seen more recently, but funding had later been reinstated. In the 1970s saw the Rochester Plan, and some of you may have been in the Rochester Plan, which was an 8-year program where students would take medical school classes in the first 4 years and liberal arts classes in the second four years along the way. That was a very, very innovative program at the time, and it didn't endure, and it merged or morphed into the Rochester Early Medical Scholars Program. Some of you may have been REM students. Yeah, I see a few hands. There you go. Right. Well, they still have the REMS program here. And as you know, because you lived it, you spent 4 years across the street. And because you academically excelled, you got to come across to us and join us for medical school, but didn't have to take the MCAT along the way. Right. Which was a good thing for all of them. The first African-American man to graduate from the medical school was in the 1940s. And the first African-American woman, Ruby Belton, graduated in 1972. So the number of women and the changes in the milieu of our student body has evolved over time along the way. So now we admit 104 students. These are the students at the end of the orientation week in August, following their white coat ceremony along the way. So that's how the school has increased in its size, reasons why it increased in size, and it still remains a family-sized medical school compared to the other medical schools in the country. Now, talking about medical education, I would be remiss if I didn't acknowledge those who came before us. And as George Whipple said here, I would be remembered as a teacher. So some of these people may have touched upon your journey here in medical school. George Whipple himself, Sanford Meyerowitz, and Jules Cohen. Jules Cohen, when I first came to work here, we were practicing in the same area, and he was very kind to me as this young faculty member who came here, and I didn't really know who he was other than a cardiologist who was in that hall along the way. And we developed a very nice relationship, and he's really had a significant impact, as did Ed Hundert and Tana Grady-Wellicke along the way. So I think it's just important that I acknowledge them. So as the student body grew, how did the curriculum change? Well, in 1925, when the school started, it was very much department-based. It wasn't very coordinated. And again, this is based upon reading. I was not here at that time. And laboratory experiences, with the third year being inpatient, the fourth year being outpatient. And World War II led to some changes with acceleration of getting students through medical school, as there was the same thing in the nursing program, to meet the needs of the war effort along the way. And it was in the 1940s that the Atomic Energy Project had a presence here in Rochester and helped shape some of the research along the way. And you can see how things developed over the years. In the 1960s, medical psychology and psychopathology became part of the curriculum, and something new called the Introduction to Clerkships began during that time. In the 1970s, you saw more classical topics that we see now, epidemiology, biostatistics, but the course Patient, Physician, and Society, which transcended the curriculum, which was a direct effect of Dr. Romano and Dr. Engel along the way. Dr. Romano coming here in the 1940s to start to be the head of the first department of psychology. And then in the 80s, the Psychosocial Community Medicine and Independent Studies program began. Now, the Independent Studies program was a very unique program where 16 students after the first year were selected to have their second year be independent study with faculty members. It was a way that they directed their own curriculum, meeting the requirements under faculty guidance. I want you to remember that one too, because we're gonna come back to that a little bit along the way. It endured for about a 10-year time period. And while not part of the formal curriculum in the 1980s was the International Health Program that was started by Dr. Lynn Bickley, and that program and those relationships, some of those relationships have endured, and we've expanded them along the way. Getting probably more current to some of our 25-year folk in the audience, the 1990s were systems-based courses, organ system-based, and IHICE began, Introduction to Human Health and Illness. And when I came to Rochester, I remember that part of the curriculum as someone who contributed to that along the way. The school had done very well accreditation-wise, but the accreditors thought that the school, they reported in 2 accreditation cycles, the school was very traditional, had a very traditional curriculum. And that led to a need for change. And in 1999, the double helix curriculum began, which created interdisciplinary courses in the scientific foundations, taught with problem-based learning, and had early clinical experiences and late scientific experiences. And there were themes and medical humanities was incorporated. That worked very well. It made Rochester a leader in medical education in the country. And if you look at other schools, they often followed that. We still have a pretty significant and robust early clinical experience compared to other schools. And we have more elective time than most schools. Sorry, I had to put those plugs in because it's important about who we are. So fast forward to 20 years, 2019, the curriculum had a renovation where we incorporated health system science, areas such as population health, social determinants of health, technology, team-based learning or team learning along the way that have led us to where we are now. And within technology, an ultrasound initiative that began more recently. So I would be remiss if I didn't really spend a moment to talk about the biopsychosocial model, as you know, started by George Engel and John Romano, based on the Sentinel paper in Science in 1977. That was really focused on patient-centered interviewing, and some of the conversations I had with you before this really talked about how that has stuck with you, and despite some specialties that you may not expect that to occur, that people have done that along the way. And that has shaped the school and its graduates, and it continues to be a huge part about our curriculum along the way. And you can see this picture of John Romano with an ashtray in front of him. I don't think we don't see that, so time's gone by along the way. So how have the fundamentals of the school continued into the present? The integration of art and science over 4 years through the double helix curriculum is really another manifestation of the original view of Rush Rees of the medical school, that it should have a leader who integrates both art and science in medicine. The biopsychosocial model is a part of our fabric, the fabric of this school. And we even have a course now titled Foundations of Biopsychosocial Medicine, Biopsychosocial Practice along the way. We teach in small groups in PBL sessions and small group learning. That does a lot of things as far as, with socialization and clinical reasoning along the way, but it helps people to work in teams. Now, one of the things that's really important about this institution that sometimes people don't appreciate is that we are a medical school as part of a university, but our university owns our medical center, and our leadership is one. And that may not seem too important to some people, but I only have to negotiate with one person about resources, whether they're clinical or not. And it was very, very important for us during COVID, and I'm going to look to Mark Taubman, because we were the first school in the state of New York that had students go back to clinical. Why? Because Mark only had to negotiate with himself about whether that would happen, and he made it happen. And so I think that's part of fundamentally what has allowed us to be as excellent as we are. And we also have our Research International and Community Service programs. Now, I wanted to stick to curriculum along the way, and there's so many things I could talk about, but I really have to return to student research. And some of you did student research when you were here. As I said, the first class, there were 3 people who took a year or 2 out in order to do that. From 1926 to from 26, 27 to 73, 74, 361 students did a year of research, at least 1 year of research when they were here, separate from the MD-PhD program. And in the 1950s, summer fellowships occurred at a more larger scale. Thank you, gosh, you're so good to me. What's going to work? Teamwork. And they were funded by departments. In the most recent year, this year now, excuse me, we have 14 students doing a year out, and 10 of whom are funded by the school in order to do so. We work to have them get external funding from prestigious organizations such as Sarnoff's, and we had 65 of our 104 students do summer research, 59 of which were funded by the school. So it's a very important part of the foundation of the school and the presence of the school, and should be and will be for the future of the school. So I'm going to switch gears now and really just talk about the journey forward in the future of medical education. There are a lot of things you could talk about. Each of these subjects could take multiple different hours or lectures along the way, but these are the 5 points that I'm just going to touch upon fairly briefly. Is what's the future with regard to curriculum content, what drives it, personalized learning, precision medicine, competency-based education, and finally, artificial intelligence. Save the easy one for last. So what drives the content of a curriculum? So why do we teach what we teach? A dialogue I have with students all the time, and I love that dialogue along the way. Clearly, accreditation drives it. LCME, they say the topics that you have to teach communication. There's an expectation of understanding the life cycle and things that go on. Now, as you may know, medical schools, which we and most medical schools have been teaching nutrition and chronic illness, have been mandated will be mandated by the accrediting body based upon a letter by Health and Human Services at the beginning of September that said that all accrediting bodies of health sciences must teach those topics and must account for the education within that. So LCME does drive it, and clearly now the government drives it as well. We are still allowed to teach about vaccines and vaccine biology. Trends in medical education and society, and you see some of those there. Social accountability. Years ago, the Canadians added to their accreditation that all schools must teach social accountability. But social accountability, although not mandated, is a big part about the topics that are coming. Digital literacy and analytics. How do our graduates access information, interpret the information, and know what information to use? Population health and management is another topic that's becoming more prominent. And how do you manage populations that within your area and outside of your area, and what data do you use to do that? Because of environment, because of global health, global warming and other things, environmental impact is becoming more and more prominent in that understanding how that affects people who have asthma and other chronic diseases, but primarily infectious diseases. I don't know if you saw Chagas disease is now considered endemic in the United States, which you would not have seen when I was a medical student and when some of you were a medical student. Or for me to have a patient who got ehrlichiosis from a tick in his backyard in Mendon. I was like, what the heck, At least I remembered what ehrlichiosis was, and then brushed up upon it. But those are things that you just wouldn't expect. And then law and medicine, I added that just because we do teach law and medicine within bioethics, but also how that may be more involved in healthcare and in medical education as well. I jumped over school-determined priorities. So what you teach in part is what your school emphasizes. So that's why we have a course called Foundations of Biopsychosocial Practice, because that's important fabric of our school. Whether it has a course in its name or whether it's present throughout, it's part of the fabric here. And another one is an ultrasound probe initiative that we've had. It's now in its beginning in its 5th year, where students get an ultrasound probe upon matriculation, use their iPads, and carry that probe through all 4 years of medical school. And I see some people surprised at that. And yep, that's what we're doing. That's a good surprise along the way. So those are some things that drive curriculum content. And also, you look at what other schools are doing, and schools look at what you're doing as well. The next thing I want to touch upon is personalized learning. And so personalized learning is really where the learner has instruction, gets some assessment, feedback, the instruction's modified, and they're reassessed. And sort of like, you think about it on rounds when you ask questions of someone, you ask questions and they're going down the wrong way and you bring them back and then you get them. that's a real life clinical. But when you start talking about foundational science and things, a lot of it is driven by programs. So it may be that you and I are in cardiology, and I don't understand valvular heart disease, but you do, and you're having trouble with heart failure and I'm not. The program will then, as we learn that, the program will keep asking me questions and instruct me until I reach a certain level along the way. So that is not to say that medical education should be taught by computers and programs, but they do certainly have a role in it in accelerating mastery of information and this is a table from Sharma et al. It's got a lot of information, but it really compares and contrasts traditional instruction and personalized learning. And some of the benefits of personalized learning are it can be very efficient, it can be transportable, and there is evidence that the retention is much better from that. The drawback is there's no socialization. And you're not working with other people. You're not in a PBL if this is the only thing that you do along the way. Personalized learning is, one of the challenges also is the finance of and vetting of programs that exist. But I think more and more you're going to see that there are certain aspects of education or CME that are done in this way to ensure that you have that information. And that's only going to grow. Precision medicine is really more about how we will practice medicine, in that precision medicine is the effective prevention and treatment based on genetic, environmental, and lifestyle factors. It's kind of like a scientific biopsychosocial approach in a way, in that you need to understand all aspects of the person's life from a molecular level to a social level to otherwise in order to provide care. But within precision medicine, a lot of it really will depend upon genetics. And I'm sure we're all familiar, we all watch television, if you're not familiar in your own practice, about that there are certain conditions where there's a genetic mutation and the targeted therapy, like non-small cell cancer and epidermal growth factor mutations and tyrosine kinase inhibitors along the way. And that makes sense in oncologists, and we appreciate that's going on along the way. But we're going to see more of precision medicine in the prevention realm, where people can have genetic testing and they're going to have a determination about how is a statin going to work for me other than lower my LDL? What genetic part about me is going to make that the right therapy for me? And in that process, just like I did not realize this, that there's a genetic mutation that predisposes people to diverticulitis. And that's just an interesting concept. And if you have diverticulitis and you have that would be interesting to know as well. But you can appreciate that the myriad of conditions that might be able to be identified or risks that could be identified through genetic testing is incredible. And those of you who practice medicine, have patients come in having gotten independent genetic testing on their own and ask you to interpret it, it's going to require a different set of knowledge, but a different set of communication skills for people in order to articulate things along the way. The gains in precision medicine are improved individual care, but also the challenges in interpreting information and working with others. And we need to be able to prepare students, and those of us in practice need to improve our ability to understand these things, interpret them, and help patients to live with the uncertainties that come with these things as well. The next thing I want to touch upon is competency-based education. And this is an outcome-based approach using observable abilities to ensure that learners achieve. How many of you work with residents and have seen competency-based education along the way? Right. And that's a big part about having people be observed, making sure that they achieve what you want to achieve, and redirecting them in other areas if they are not achieving it. It is probably, I think, more feasible at a graduate level than at medical school, but competency-based education has a growing following and a growing movement in undergraduate medical education. And in order to have it, you have to define what are the real observable things that you want to have somebody do. So if it's you want someone to be able to do a postpartum check on a patient and be able to identify what they need to look at and what the scenarios are along the way, that has to be really well described. But also your observers all have to be on the same page. So you have to have faculty members who understand what that is, can give feedback, within it and are consistent across, and define how many. Is it a one time they do it? Is it 10 times they do it along the way? It is faculty intensive along the way, but for those individuals who've been through it, find that it is actually very helpful because it gives immediate feedback in the moment, unlike sometimes where there's a delay within feedback. So competency-based education, these are just some of the things that have helped in that movement. Is the AAMC developed core competencies for entering medical students that some schools use in their admissions process along the way. They recently came out with foundational UME or undergraduate medical school competencies that match those of GME to provide some overarching guidance. More recently, as Sarah mentioned, I was able to work on the group that developed telehealth competencies for learners and providers along the way. And this predated the COVID pandemic when telehealth took off. So ACGME, some of them now, if it's competency-based, have accelerated residency programs. And a big one is the orthopedic residency in Toronto was the first one within that. And it sort of reminds me of, how many of you remember the show Kung Fu? And he said, grasshopper, when you can get the pebbles from my hand, you can leave. It's kind of like that, but a little bit different. Is that when they reach that certain point, they can depart from it, from the residency, or they can leave. Now sometimes that creates some disruption in scheduling along the way. So some programs have used sort of a pause in the residency, that once you achieve those certain goals, you don't necessarily leave the residency, but you get to do things that you want to otherwise along the way. And so ACGME has been a leader in that, and the Canadians have been a leader in that as well. Again, having defined goals for people, does it improve outcomes? There's some evidence that it might, although patient outcomes based on these things are not always easy to determine. And it is labor intensive and requires some degree of consistency. The last thing I'm going to talk about is AI. And I mean AI, not A1, which some of you may know that our Secretary of Education referred to this in April as A1, saying that all schools should have A1 in their classroom. The Heinz Corporation got pretty excited about that, I think, a little bit, but I'm not going to talk about A1, although I do enjoy a good steak, but rather artificial intelligence. Now, I could be talking for a long time about artificial intelligence, and so don't worry, I'm not going to. But I want to touch upon it in a couple of different areas because it really permeates all of our lives, regardless of whether you're in medicine or not, just by touching your phone, just by everything that you do along the way. And so, you know, there's AI where it enables computers to simulate human intelligence or deep learning models or language models along the way. So how does AI and medical student education, how do they intersect? Well, one is possibly in admissions, in admitting students, and using AI as a screening tool. Now, you know that we can screen the admission. I don't sit in the admissions committee, but the admissions process can screen students based upon GPA, MCAT score, things like that along the way. That's not new or rocket science along the way. But there are programs that are being developed that will screen all aspects: personal statement, letters, CV, things like that, looking for certain features along the way. Now, these programs require some human judgment along the way, and the schools that have used it to date have done trials where they take the applicants, AI does it, decides who to interview. It's really for interview. It's not for admission, okay? Interview, and then they have their own process go, and then they look to see what's the relationship between the two. How much do they agree? The agreement for most of them tends to be very good. There are some lapses along the way. And if AI is going to be used in the screening and admissions process, there needs to be human judgment, as I said, and an understanding of the ethics that are associated with it. So privacy. So certainly these have to be in closed systems because people's personal information is on it. And then how accurate is it? And then does it comply with laws and things along the way? The thing is that this allows a school to identify certain characteristics or things that it's looking for in its applicants and pull those out. And I don't, I'm not going to hypothesize what they would be, but they may be a certain research or students who've worked with the homeless or worked with the underserved, things like that, that the programs can go through and pull those things out along the way. This is not something, as I said before, that we're doing here, but there are schools that are using it, at least preliminarily, and these are proprietary. They create them for themselves, for their own goals. In medical education, there are certain things that we should teach about AI, certain applications in technology, and making sure that faculty and students understand what resources do you use for AI and how do you interpret it? Because we know it's not always right. I don't know if you've used AI, you use it, and sometimes you get step back, you're like, whoa, I know that's not right at all. And how do you interpret that? And also the ethics of when do you use it and what information do you put into it? We we tell students you can't put information in and have it generate a patient note, even though some of my colleagues and some people here, and maybe you, use your phone when you interview a patient and it generates the preliminary note for you. We don't let our students do that. We like them to think of it all along the way. But what they do with information outside of here, the ethics of that is important. And it's important for a school to define how can students use AI? Because if you deny that it's there and you say don't use it and they don't use it, then they're going to use it and they're probably not going to use it in a way that would be advised along the way. So those are some of the things that we want to do. Now, AI would be great for mentorship too, to help statistically. Am I likely to get into the medicine program at blank or something like that? And also, as I touched upon before, AI as a personal learning tool is important. And it can help with interprofessional education and collaboration. So one of the things I did was I said, how can I show how someone could use AI in a medical student program? So I asked the AI, I said, generate a USMLE Step 1 question about the pathogenesis of amyloidosis. Now, why did I do that? A few reasons. One is because I know our students are doing that. I know that they're taking a syllabus or part of a syllabus and they're putting it in and they're asking it to generate study questions to help them to learn. And the other reason I did it is sometimes faculty do this to give them a template to write a question. And I also did it because one of the first patients I saw as a medical student in medicine had amyloidosis. So it stuck with me and I can actually see him now. So in his memory, because I'm sure given my age and the disease that he has since moved on. But this is what it gave me in a matter of seconds. Okay? So if you've ever written questions for the national board, you have a STEM, which is the question there, talks about the patient, gives the history, physical exam, some important lab, and then a variety of different answers along the way. So this could serve as a way for someone to quiz themselves or for someone to use as a template for an exam, a summative exam. Now, the other thing is what about AI as a communication tool? And this is something that we're piloting here now. So in conjunction with the computer science department here, Ron Epstein and Tom Carroll's in my division. This is SOPHI. SOPHI stands for something I can never remember, but for this purposes, this is just SOPHI. And this was developed for faculty and fellows to help them to practice having a difficult conversation. So you log on. Sophie is you're told Sophie's a patient who's coming for follow-up. She has recurrence of her cancer. There is no treatment, and you have to deliver the bad news. And so you will ask Sophie questions, and she will answer. She's an avatar, but I got to tell you, the first time I saw this, I can be skeptical. I understand about it, and I was kind of blown away by it because of the interaction, facial movements, and things like that. So you go through your experience, and then you end it. And then Sophie tells you, as you can see here, what was your speaking rate? Mine is probably above 66.2 words per minute. What were the number of questions that you asked? What were the number of open-ended questions you asked? What was the turn taking? Did you have a period where you may have been dominating? And I say may have been dominating because there are times where you have to deliver a lot of information without interruption along the way. Sentiment trajectory. It can tell you the level of education that you taught. It gives you a written feedback in three different areas, okay, within seconds, all right? So a few things I want to say about this is that, and the other thing that you could potentially do is you could make Sophie younger, older, have an accent, different education level, different appearance, things like that. And you can imagine the permutations that would go from that. The thing is that please don't think that this is how we teach communication or that how we should. All right, I really want to touch upon that along the way. But you can appreciate that if I know that tomorrow as a second-year student, I have to go in a room with a standardized patient and talk to them about tobacco cessation. If I could do something like this at home first in the quiet of my little nest, I would go in there a little bit more comfortable with a little bit more experience along the way. The benefit of Sophie too is that Sophie just interprets. So it's not like my perception of how you did, your perception of how the student did, your perception are different. It gives that type of feedback. So this is a way where AI can be used to help with communication, help with instruction. We now require it in the medicine clerkship only that students complete it. We actually don't even look at what it did, how they did along the way. It's just that they completed it along the way. That's a beginning part of the pilot. I do not see us using this as a grade for a student in any way, but it may help us to understand the skills that our students have in areas where early in the curriculum we may be able to lead to improvement. The last one I did was, again, for a faculty member. I said, generate learning objectives for a talk to medical students on essential vitamins, along the way. And this is what it gave me within seconds. Now, as someone who teaches, and those of you who teach, it's kind of nice to have something that you can work off of rather than you create de novo. And I think that learning objectives on essential vitamins is not something that's necessarily new, but this is a way that AI can be used to help drive a curriculum. And it's written in very good verbs for learning objectives along the way, and it fit right on the slide as well. So these are some examples of where AI can be used for instruction, for assessment, and for independent learning. But so AI can also be fun. And so I asked AI, I said, change this picture to look like a Van Gogh painting. And I gave it this one here. And it gave me this. And because I didn't tell AI who it is, it gave me its own interpretation, portrait of thoughtful manager. So I was having fun, and I hope you had fun seeing that as well along the way. But it was just a nice experience along the way. So the next century in the medical education here or anywhere is going to continued explosive increase in knowledge and expanded technology. And I touched upon some of the areas where we continue to do traditions of the school, but where we will have challenges, good challenges going ahead. We're going to need to continue to adapt to that, both as instructors, learners, and practitioners along the way. And through this, the importance of communication is very, very key. Not only oral communication with patients, but written. Those of you who handle my chart messages, sometimes we have to be very thoughtful about how things come across in writing, which is different from how they come across verbally, and making sure that you attend to things along the way. And I think that will be a challenge that we will meet at this school and other places along the way. So we went from a graduating class in 1929 to a graduating class in 2025 along the way. And you all benefited from the legacy of those who started in 1925 and were part of the legacy that those who followed you have benefited from. And I look forward to you being part of the legacy of the future if the school is going to stay to its essential foundations along the way. So, Meliora. Thank you for your attention. I think I'll handle, if anybody has any questions for me, either as a large group or afterward, you can certainly come down.
So it was brought up in our Carl Soderlund class of 1975, stayed here for 4 years of residency as well, and almost stayed, but we moved back east. Anyway, it was brought up in an earlier talk about shortages of primary care, but there's a workforce imbalance going on in healthcare. I didn't hear anything in this. And what's the school's responsibility to help come up with the right number of physicians or right distribution of physicians?
Right. And there are a lot of things I could have covered along the way. I'm starting to cover that. So when people ask me what kind of student Rochester produces, I say an excellent student. I think our curriculum is designed to let people do what they want to do. I personally don't see that it is the school's responsibility to produce a certain type of physician. I think that there are schools out there that have that direction. I think it's important that students work with role models and people who are passionate about what they do, and that's what drives them. So personally, I became a general internist because of the general internist that I saw and I worked with in medical school along the way. So that's my thought about that. I agree that there are shortages. There are shortages in underserved areas. We have a couple people in the audience who work in an underserved area where I'm from, where I grew up and I worked with as a medical student. So I have that perspective along the way.
Yeah, hi. Thank you for the great talk. Are there initiatives where I would imagine the future patients are going to do a lot of interaction with the computer and entering all that stuff, and they're going to walk in the room to see the doctor, and they're going to hand the doctor a piece of paper that says AI's already listened to everything, and we think this patient has X, Y, and Z. So is that something that you're looking at?
Something I'm experiencing
Yeah.
nearly every day. I think it gets in part to being able to interpret information and communication skills and be able to say uncertainty. You know, within the last month, I remember just saying to someone, I don't know, and I need to get back to you. You know what I mean? I'm not in this 20-minute appointment going to be able to figure that out. But at this point in my journey, I'm comfortable saying that, and I think my patient was comfortable hearing that because I did get back to them along the way. But I think it's just like when people brought articles, it is different. The volume of information is much greater. And if they're starting to do searches that are assimilating information and resources that are less clear, it does become more of a challenge. I think understanding uncertainty is a big challenge in medical school because you come into medical school thinking, you know, yes, no, disease, not disease, you know, cure, not cure, and it's kind of the challenge and the beauty of medicine.
Hi, thank you for your talk. As I look back on my own medical education here with Dr. Engel, there are three gaps. One, the internet didn't exist yet, but it's an enormous challenge to cope with patients who are interneting themselves before they come in. And I hope that that's part of the curriculum. The electronic medical record, which didn't exist then, is a huge challenge because it flies in the face of talking to the patient. It competes with your interaction with the patient. And the third thing that was lacking in my education was business of medicine.
Right.
You've got Simon School over here, and I don't think we spent 1 hour on the business aspects of medicine during those 4 years.
Right. And speaking to the business aspect of medicine, there are some foundational things that we teach about to understand health systems, financing, Medicare, Medicaid, things like that. Specifics of specialties are generally relegated to GME, but understanding health economics and those things is very important. Students are really surprised to learn that the same patient can go in and get the same exact care and have very different costs associated with it and things like that. And they do get an appreciation in the longitudinal ambulatory about the different aspects of billing and capture, but that's not a formal part. You know, it's tough because there's a lot you want to teach, and for everything you add, sometimes you have to take away or condense. And we don't want to make medical school more than 4 years.
Excellent discussion. It took me quite a while to recognize that a lot of my colleagues from other schools did not have the fabric of biopsychosocial in their education.
Right.
And occasionally someone would come to me and say, hey, have you heard about this? But one of the things that I'm an occupational medicine physician. And one of the things that I've learned over many years, and I'm afraid it's somewhat true still of Rochester, is that we don't often ask about what people in their younger years do a third of their time. And it often is not considered in the biopsychosocial aspects of medicine.
Right. Yeah, because sometimes you learn things about your patients earlier lives very late on. along the way. And I just wanted to share an anecdote that reminded me, and I was going to put it in here, but in time I didn't, but here I go. Is that I have a great job. I have a fortunate position here. Take care of patients, and I'm involved in the medical education program. I work with great leaders along the way. But I also hear from alum and from other people along the way. And we're part of a consortium of medical schools. We get together, and there's a woman who oversaw the education program at Duke, and her daughter gave birth to a child that had esophageal atresia and was in the unit there. And so she went to the unit and, sat there because it was her grandchild. And she said the team came in, and when they were done talking about the child, the intern came over to her, sitting in a chair, got down on her knees so she was eye to eye, and say, "We've talked about your grandson. What do you need? Is there anything that we can do for you?" And she said, "Where'd you go to medical school?" And she said, the intern said, "Rochester." And then I got an email. So that's there's one of very many that just sort of those and the program director things that help us to understand that what has been done here and will be done here has an impact. Those one at a time.
Oh, great, thanks. Thank you so much for that talk, Dr. Lambert. Yvette from class of 2000. I had the privilege, class of 2000. We have a lot of us here. I had the privilege of being involved as one of the medical student representatives to the development of a double helix curriculum, and being in med ed for quite a while now. One of the questions that always sort of comes up for me, and I'm wondering if U of R has been thinking about this, is we really truly transition to competency-based education, which of course is really resource intensive to do well. Is there, you mentioned the 4 years, which is what brought this to mind. Has the school talked at all about looking to, instead of time-based education, to truly competency-based education, knowing that it may be shorter for some students,
Right.
longer for others, and obviously logistically challenging, which I think is one of the things that has kind of stopped us from fully going there. I was just wondering if that's something that's come up.
Yeah. And so just within competency-based education, one of the things that we've developed is a cadre of expert assessors, which is a group of physicians who do assessment of clinical skills in the first 2 years. So there's consistency along the way. I think we're in our 3rd year of doing that, and that's made a huge difference in the feedback students got and leveling the playing field and making sure people achieve things along the way. We've not really discussed time-based along the way, but one of the things that certainly comes up, and other schools have done it, is transitioning to residency within the same institution. In other words, when you're ready, when you're done at this point, then you can go on to your medicine residency or something like that. Time-based education for medical schools gets a little bit complicated with student status, loans, time to get a job. Do you know what I mean? Because if there aren't necessarily residency positions open in February of the final year along the way. But I think that within an institution can make those kinds of changes. So we've thought about it, but we've not acted on it. And I think for this school and this community, I wouldn't advocate a shorter time than 4 years, at least right now. But it is very interesting and where we're going.
So I do some work with Tufts Medical School, and I am appalled at physical exam, excuse me. And I'm trying to figure out, am I old fashioned? I was taught with Bill Morgan and Paul Greiner, and you had the clothes off, you did all 4, you looked, you examined, and that doesn't happen anymore. Heart exams are through shirts. I have patients since now that I've retired that go see other physicians and don't take their clothes off for physical exam. Is it me, or are we teaching physical exam? Is it important to do it anymore? Now you can do echoes and ultrasounds and everything else. Where are we in Rochester that?
So I think it's important, personally, along the way. And we do teach physical exams. And actually even with standardized patients, it sort of points off if you listen through the gown, for example. Do you know what I mean? And that's what these expert assessors are to do, is to have those skills. I think one of the things that happens, unfortunately, is skills degrade if they're not reinforced later on along the way. And that's an unfortunate thing, but it is very, very important that I believe that people have those skills and have. Well, I'm not sure you're old, but But no, I don't think that it is. I think that that is a very, very important series of skills to have.
Hi, Beth Lovell, class of 2000. I work with first and second year medical students at UMass, and they're wonderful, but they are obsessed from day one about research. And as a medical student here, I got to volunteer at a homeless shelter for women and children. I got to go to Costa Rica on a project there and felt like I had time to do other things for downtime. And the students that I work with now, all they are interested in is research. And I know research is important, but so is becoming a doctor. And I'm just wondering what the temperature is like here.
So I think what we're seeing is a unexpected, unanticipated change as a result of step one going pass fail. And you think it should be a pass fail exam. It's a licensing exam. It's like, can you drive a car or can you not drive a car? I mean, it's not quite like that practicing medicine. I get it. And so the ability to distinguish oneself doesn't happen from an academic standpoint at schools where most schools are pass fail. So they feel a need to do something else, and they perceive that research is the thing that will get them to the residency, and that's what it is. It is a very different temperature for incoming students than 25 years ago along the way. But that said, and I did emphasize research in my point, and I touched upon international and probably could have expanded upon that, as well as our community service programs, which are a big part of the institution. And our admissions committee really looks for people who have done something in one of those areas along the way. So it is an important part of the school. And I didn't talk about how the original Strong Hospital, which opened a few months after the school started, had the Rochester Municipal Hospital was 2 wards within it. And in the 60s, the institution bought those because it was a public, it did take care of the public. It is part of the beginning of this, and we are the catchment tertiary facility here. So I think those things are very important. We do emphasize them, and we have students who are very active in those. But I think that there's a bigger medical societal change that has driven students into exactly what you're seeing. And one of the things we see is students, not attending things because they say, I need to shadow, I need to do this, and trying to get them. So yeah, reality, fortunately. All right. Well, thank you all for your attention. I'll hang out if there are individual questions. It's good to see some of you who I've crossed paths with in a variety of different ways. So welcome back and thank you.
That was excellent. Dr. Lambert, thank you. Please, all of you, join us for a reception we're having in the Flom Atrium. And if you're lucky, we might have a little toast to celebrate our 100th anniversary of our School of Medicine and Dentistry. So please go out to Flom and enjoy and connect. Thank you.